This is Focus on Your Health. It's brought to you by Kingman Regional Medical Center in historic Kingman, Arizona. I'm T.G. Lafredo, and this week I'm coming to you from KRMC's Hualapai Mountain campus. My guest is Dr. Thomas Gaughan. He is the Chief Medical Officer here at KRMC. Dr. Gaughan, welcome.
Welcome myself. Yeah, I'm glad to be here.
I'm glad to have you. Thanks for taking time. I know you've got a crazy busy schedule. Appreciate that you came by to speak with us. Today, well, us being me, that's the editorial we, I suppose. Yeah. Today, I want to talk a little bit about quality measures at KRMC. We released the news recently about the Leapfrog Group. That's the organization that rates hospital safety. And we'll talk about that. I want to get some of your perspective on that. I want to know a little bit about the Chief Medical Officer, what he does, what your role is around here. So, are you ready to jump in?
Sure.
So let's start right there. CMO, what does your job entail here at the hospital?
Well, the short version is I have oversight over the providers on the medical staff in terms of assisting the medical staff organization in assessing provider competence and quality of care. I have oversight of the graduate medical education program related to our training of physicians in emergency medicine and family medicine, also the medical students that come through our facility. And then I also have oversight of what you're interested in here, the quality management department, which includes hospital safety, patient safety, infection prevention, environmental safety, internal auditing, things like that.
You come to this work as a clinician. You are a board-certified psychiatrist, and you also did some training as a pediatric. You did an internship, is that correct?
Yes, internship in pediatrics.
Yeah, so you've got multiple perspectives on work at the hospital and what the different providers have to do. How did you find yourself in the front office, or what was that interest for you to go to the administrative side of things?
Oh, that's probably not a short answer, but basically I practiced inpatient psychiatry for many years, was actively involved in other activities and leadership activities in General Hospital, and gradually moved over more into an administrative role and left clinical practice behind.
Did you find, even as a clinician, that you had a mind for systems, that you were thinking about how to improve or how to streamline different aspects of were you already thinking about that then?
Well, medical care, whether you're taking care of patients or in administration, is always focused on providing quality care, on how we can improve care and how we can do a better job to kind of quote Walmart a little bit. The government would like us to see it done, faster, better, and cheaper, and that applies to healthcare. And to do that and hold on to quality and safety are already buried in patient care. I just was more involved in processes and working on the larger picture, and at some point realized that I could have a bigger impact on patient care in an administrative role than I was as an individual practitioner.
Better, faster, and cheaper they can be competing agendas, right? I mean,
yes. Medicare calls it the triple aim. They want to have better outcomes. They want to have better customer experience and patient satisfaction, and they want that to all occur at less cost, which are all laudable. I'm a taxpayer. I agree.
Yeah.
So,
and if you had three wishes, it's the right number. So it's tough to balance all that, those competing needs. I'm guessing.
There often are conflicts.
Yeah.
Yes.
So sometimes I find myself speaking with administrators and people who run certain departments, and I think, it's very interesting, but I don't admire that job. I wouldn't want that job because I don't know. It's a balancing act, yeah?
It is a balancing act.
Yeah.
I'm not always popular.
Well, part of what you do, you need to know what's going on with all the different providers in the clinics. You need to think about addressing the needs of the community and providing care. And there's been a lot of talk about a shortage of physicians throughout the country, not just here. Kingman is a medically underserved area. Mojave County is. What does the future look like in terms of, medical service? You know what I'm getting at?
Well, I think so, and the answer isn't a good one. It's difficult that the number of training positions for physicians that graduate medical school, that go on to do residency training in a specialty, and that includes primary care specialties, the number of training positions has not really increased much in the last 20, 25 years. The funding for that has been frozen, and yet the population has increased dramatically. So there is a shortage of providers, and that is being partially offset by use of physician's assistants or nurse practitioners. But in general, there's a national shortage of providers. It's been subsidized by foreign doctors immigrating to the United States, but there are also limits on the number of training visas and work visas.
Talking about staffing, is this pretty much the norm everywhere? I mean, is there a hospital anywhere in this country where people are saying, "Oh, I'm so glad we're at full staff," or is it just this is the fact of practicing medicine today?
Well, I think even if you go to large organizations, Mayo Clinic, Cleveland Clinic, Intermountain Healthcare, Kaiser, that they will always have particular areas that they're short of the number of providers they want or the quality of providers they want. It's not just having a warm body, but it's particularly acute in a place like Mojave County. We've actually recruited an awful lot of providers that want to live in a more rural area and have that lifestyle, so it actually becomes an attraction. But all of these providers and physicians train, or most of them train in big cities. Part of the way we've attracted people is by training doctors here at Kingman, and our family practice residency program has been very successful in training and then retaining those physicians in the community. It is the only way we would attract people into the community. That we have only, in the time I've been here, which is 5 years now, I think we've actually only recruited one practicing family physician from outside of Mojave County to relocate here.
An aspect of what you do is quality management. What does that mean? For the layman, what does quality management entail at a hospital?
Try and do a brief overview. I think it entails making sure that the care provided in the hospital is safe, that people don't go home with more problems than they came in with, making sure that we meet national standards for outcomes related to mortality, complications, success. So we measure ourselves against other hospitals, and then making sure that we have up-to-date processes. It isn't enough to have just a good provider that knows what they're doing if we don't support that provider with good processes that allow them to do the best job they can. So it's about competent individuals, and it's about best practice processes.
When you speak of processes, does that also include technology and trying to stay on the forefront of that?
It would be including technology. Technology is a mixed blessing. Yeah. Sometimes the technology that's been made available in medicine has not necessarily been as sophisticated as it needs to be, but we've adopted technology anyway. Maybe not the right answer for your question, but
it's an interesting.
Technology is a mixed blessing, and
Yeah.
I think that the mandate when I think of technology over the last 10, 15 years has been to adopt electronic medical records, and a lot of the medical records that were offered to us 5 and 10 years ago weren't ready and didn't get the job done, which is why we're moving towards implementing a new medical record.
It's on my list. I'm dying to ask you about it. I know that we've done some shows recently where we've talked about that, the new EMR or EHR, which is electronic health record, electronic medical record. They're synonymous. There's a new system that has just launched here at KRMC. It's called OneCare. Previously, there were at least 3 systems in place.
6.
Oh, gosh. Okay, there were 6 systems in place. What is the problem with that?
The problem with having multiple systems is that they never talk to each other the way you would like them to. So if you're a patient moving from the emergency room to surgery and then to the inpatient unit and ultimately to our outpatient clinic, you'd like to think that all of your information about your care travels with you. In those multiple separate systems, that information had to be gathered each time you changed levels of care. So the emergency room would gather all your medication and medical history. It wouldn't go with you to the OR. They would have to ask you all the same questions again. And then same when you went to the medical floor or to the outpatient clinic. Clearly, the more handoffs in medicine that you have, the more that data is manipulated, the more room there is to make errors or for things to get dropped or lost.
When I heard about this system, I thought, how could it be so fragmented? It doesn't make sense. And yet I've been told this is pretty much the way it's been in institutions across the country.
At the risk of being politically incorrect, I would say that's been particularly true for middle-sized hospitals, that the original good systems were either built for very large hospitals and systems, and they would only sell them to large hospitals and systems, or they were built for very small systems, very small hospitals, and middle-sized hospitals were forced into a market where there were multiple vendors, but there were no real integrated systems, and yet they had to adopt something, so they were sold immature systems, and many of those companies have now fallen by the wayside, and now the more mature systems have been willing to sell to the middle-sized hospital market, and so that we're taking advantage of that and consolidating into a single integrated electronic health record that will be available in all of the different venues where we provide patient care.
It's time for a quick break on Focus on Your Health. We'll be back in a moment for more with Dr. Thomas Gaughan. Stick around. Support for the Arizona Community Radio Network is provided by Kingman Regional Medical Center. KRMC is pleased to recognize Dr. Justin Garrison and Physician Assistant Curtis Manley, winners of the Physician Assistant Partnership of the Year Award from the Arizona State Association of Physician Assistants. This award is presented to the doctor and PA collaborating to improve patient care. KRMC. Welcome back to Focus on Your Health. I'm T.G. Lafredo, and this week my guest is Dr. Thomas Gaughan. He's the Chief Medical Officer at KRMC. We're talking about safety and quality measures. The Leapfrog Group is a national organization that rates the safety of medical institutions across the country. They promote themselves as nonprofit and otherwise non-affiliated. And they just released their spring 2019 hospital safety grades, and KRMC has received an A rating. So this is big news. I guess that's a question. Is this a reason to celebrate? Is this a great...
It's welcome news. We're excited by it. It's something that, well, I wouldn't say we've strived hard just to get an A from Leapfrog, but we've strived very hard in the 5 years that I've been here to improve the safety of the care we provide. And I think the Leapfrog grade is a nice recognition of the fact that we've made tremendous strides in the areas of safety for patients in the hospital.
There are numerous organizations that do just this sort of thing where they rate hospitals and organizations. Is that correct?
There are a number of consumer agencies that have their own way of evaluating the quality of care in hospitals, yes.
So you're giving me sort of a wry smile. So I'm gathering that perhaps each has its own measurement devices.
They each have their own yardstick, so to speak, for measuring quality. They each have their own definition of what quality is. Leapfrog is a little more straightforward in the sense that this particular survey is published twice a year and focuses on safety, on preventing avoidable problems. But some of these other organizations will use questionable measures. Sometimes they will pick measures because the measure is easy for them to get rather than really meaningful. So I would say that a lot of those assessments have inherent flaws, but that's part of the problem. It's complicated work, and it's hard to measure hospitals against each other without simplifying things and sometimes oversimplifying the comparisons.
Was just a few years ago that KRMC received a poor rating from Leapfrog. Mm-hmm. Can we talk a little bit about that? What went into that?
We can, sure.
Should we not?
No.
You're in charge.
We're pretty upfront about it. We did.
Yeah.
We got a poor rating several years ago. We got a D. We didn't think it was a fair rating. It reflected some inaccurate data that had been reported to the government. At the time, we didn't participate in Leapfrog, so Leapfrog then goes out and gathers their information from other agencies like the federal government, and they assume it's accurate. This data wasn't accurate, and the Center for Medicare Services knew that, but were unable to correct the data at the time, and Leapfrog used that anyway. So we had some mixed feelings about that. But we could have stayed angry at Leapfrog, and what we chose to do instead was to say, look, we're already on a safety journey. Let's prove that we're getting there, and let's participate in Leapfrog, and let's embrace them and not just do it our way, but we'll do it their way just to show that, yes, we can be a very safe organization.
So, I mean, clearly there's some pressure. The way that the organization presents itself is says that, like hospitals across the country voluntarily participate, but it's not entirely accurate.
It's not entirely accurate. As a participant, they get their data, we give them permission, and we feed them data that they want. So it's more up to date, it's more accurate. It's still related to metrics that they have chosen. We don't get to decide what they measure us by. If you don't participate, as I said, they gather data from other sources that is typically 3 or 4 years old and it has not necessarily been verified or accurate.
I recently spoke with Brian Turney, who's, of course, the CEO of KRMC. We were talking about just this matter, and he was saying that at that point, we were probably realistically about a C. We weren't an A. And so we just saw it as, hey, let's accept this challenge. Yes, we're playing the game. I'm paraphrasing, but yes, we're playing the game, but let's accept this challenge, and it is an opportunity for us to improve as an organization. What are some of the steps that KRMC took to make those improvements?
So again, Leapfrog tends to focus on safety and prevention of avoidable problems. So the things that we've worked on are preventing infections that are acquired in the hospital. It's one thing to come into a hospital with an infection. It's another thing to get it while you're a patient there, whether it's after surgery or while you're on one of the medical floors. So we've worked hard to prevent those kinds of infections with great success. We don't want people to get blood infections. We don't want them to get bladder infections because of the care they're receiving. We've worked hard on preventing falls. Patients that are weak and sick are prone to fall and get injured. You could argue that, well, that's not our fault, but the reality is it behooves us, they're in our care, to do everything we can to prevent any kind of falls that result in injuries. It's improvement in our electronic health record. It's making sure we have that clinical decision support and that we have standardized care whenever it's appropriate to make sure that we can deliver good care consistently in the right places. We've made major changes in upgrading the care in the intensive care unit. We actually were very proud of our intensive care unit even 3, 4, 5 years ago. But there's always room for improvement, and we've made changes where our intensive care specialists, our intensivists, are on the unit 12 hours a day. When they're not on the unit, we've had special training for nurses to become they use the term effectors, and to be able to be better prepared to be the hands and eyes and ears of the intensivist when they're not on the unit, say at night, so that we've upgraded the availability to intervene at night and for the intensivist to get back to the unit when they're not there. We make sure that when a nurse calls a physician at night from the intensive care unit, that they get a response in less than 5 minutes, usually much less than 5 minutes. So those are all little things, but they add up to great improvements in care.
When we talk about that wide range of changes and improvements that you've made, I wonder what happens next. I know one thing from speaking with doctors and administrators for several years now, that complacency is a dangerous place. It's not like, well, we have our A, we've arrived. But what is next? How do you continue that trajectory of growth and improvement?
Well, the first thing when you think of quality improvement is we have to make sure we maintain the improvements that we've made. Hospitals and organizations in general, it's very easy to fix things than to walk away from them and watch them fall apart again. So maintenance of the gains is huge. Frankly, the new electronic health record is probably the biggest project for this hospital in the last 10 years or for the next 10 years. And it doesn't necessarily come without kinks right out of the box. So as we turn this new system on, we're going to be devoting a lot of time to identifying and ironing out unexpected little things that will occur with it and to make it more efficient and to work the way it was designed. We're always working on efficiencies in care. It isn't just the safety of care. We want to provide care in the shortest amount of time possible with the best outcomes we can get. We want to make sure that, we hadn't talked about it, but we also in the last year have implemented 2 other software systems. One is a quality data collection system, which is we call it the clinical database, which is developed by a consortium of the largest university teaching hospitals and made available to us through a group that we belong to called Vizient. So this is a up-to-date data management program for quality that will allow us to compare ourselves to the top 110 university hospitals in the country and also to high-performing institutions that are also part of this consortium, which will include hospitals like Mayo Clinic, Intermountain Healthcare, places that are seen as leaders. The university hospitals here in Arizona all participate. So we've raised the bar in terms of who we compare ourselves to, and we expect to be competitive. That's the challenge we have, is we want to be doing as well as they're doing or better.
That's Dr. Thomas Gaughan. He is the Chief Medical Officer at KRMC. Dr. Gaughan, thank you so much.
Oh, you're welcome. Glad to do it.
And that is another edition of Focus on Your Health. I'm T.G. Lafredo. Thank you so much for listening. We'll catch you next week.